I'm going to start broadcasting. Good morning, everyone. We're going to get started in just 1 minute and allow everyone to log in. Good afternoon, everyone. Thank you for joining us today. We're going to get started and I'll hand it over to our Deputy Director for Policy, Chris Bostic.
Great, thanks, Michelle. And good afternoon and morning to everyone joining us, and thank you for being with us today. My name is Chris Bostic, and I'm the Deputy Director for Policy at Action on Smoking and Health, or ASH. If you're not familiar with ASH, just very briefly, we've spent about half a century fighting the tobacco epidemic, and for the past several years, we've rooted our work in recognized human rights, equity, and social justice issues. The two programs that stem from our human rights work are legal liability, including criminal liability for the tobacco industry and its executives, and Project Sunset, which is a global campaign to phase out the sale of commercial combustible tobacco products. Today, we'll be discussing the intersection of state and local policy responses to COVID-19 and commercial tobacco prevention and control. Many of you have been with us over the past 3 months as ASH explored various aspects of the nexus between COVID and the tobacco epidemic in a series of webinars. Today's discussion is a direct result of questions we received during those webinars, the questions that we were not equipped to fully answer at the time. Fortunately, we have friends who are equipped to answer those questions. We're very pleased to have two distinguished colleagues from the Public Health Law Center join us today to walk us through these issues. First, Rachel Callanan is a senior staff attorney with the Public Health Law Center, where she provides legal technical assistance on commercial tobacco control issues to public health professionals and organizations, legal professionals, and advocates in Minnesota and throughout the United States. Prior to joining the center, Rachel was Regional Vice President of Advocacy for the American Heart Association, where she led policy work in healthy eating, physical activity, and tobacco control policy. With almost 18 years of experience on the front lines of passing state and local policies, Rachel has also led nonprofit advocacy with the Minnesota Coalition for the Homeless, Minnesota Housing Partnership, and Minnesota Now, and worked as a research associate at the Institute on Race and Poverty. We are also joined by Jessica Grosz, who is also a lead senior staff attorney for National Legal Technical Assistance and also supports the center's nationwide provision of legal technical assistance to public health advocates, state and local health officials, and government attorneys working to advance health through commercial tobacco control-related laws and policies. Prior to joining the Public Health Law Center, Jessica led the Agricultural Worker Project at Southern Minnesota Regional Legal Services, where she provided legal representation, education, and outreach to agricultural workers to help improve their working and living conditions. She previously acted as a farm worker attorney at the Oregon Law Center and Legal Aid Services of Oregon, as well as a faculty immigration advisor and equity consultant at North Dakota State University. During law school, she held various legal internships focused on immigrant rights. She is bilingual in English and Spanish. The speakers will provide background on the authority for state and local actions and highlight strengths and deficiencies of COVID-19 policies in the context of commercial tobacco control. They will also discuss both issues relative to the racial injustice in America that is finally a national conversation. After the presentation, we will have a Q&A discussion. At the bottom of your Zoom screen is a button to submit your questions, and feel free to do this as you listen. With that, I will pass the baton to Rachel.
Great. Thank you, Chris, and thanks to ASH for hosting this fantastic webinar series. It really has been very educational and helpful to understand the current status of affairs. So Jessica and I will be talking about U.S. commercial tobacco policy and enforcement during the COVID-19 shutdowns. But first, a very quick background on the Public Health Law Center. The center is located in St. Paul, Minnesota at the Mitchell-Hamlin School of Law, which is located on the lands of the Dakota people. We're a dedicated team of attorneys, policy analysts, and support staff who work nationwide on public health policies in the area of commercial tobacco control, healthy eating, active living, and health equity. So as a nonprofit organization and with support from our funders, Public Health Law Center provides free legal technical assistance across the United States. And special thanks to Robert Wood Johnson Foundation and the Minnesota Department of Health for their support in funding the research for this webinar today. Our legal technical assistance includes research, publications, trainings, and webinars on a wide range of topics related to public health. We also assist communities with policy development and can review state and local policies and provide sample language to achieve public health best practices. We do have some limits on the work we do. We don't provide direct legal representation, and we do not lobby. If you are interested or would like some legal technical assistance, please do not hesitate to reach out to us. So the work that we do at the center is done in consideration of advancing equity. And what that means is we are committed to partnering with communities and organizations to use the power of law in a way that addresses the social determinants of health and meets the basic specific needs of all communities, especially those who unfairly bear a greater burden of health inequities and other societal harms. We do not believe that equity is achievable through a one-size-fits-all approach. We would like to begin this webinar by acknowledging the crisis in our communities right now. The Public Health Law Center joins the protesters here in Minnesota and across the world in calling for justice for George Floyd, Breonna Taylor, Ahmaud Arbery, and the many other Black people who have been murdered by law enforcement in the United States. Racism is a public health crisis that demands sweeping policy and systems changes. We renew our commitment to uprooting white supremacy and breaking down structural and systemic racism through our work as public health advocates. And as you'll see, much of our talk today centers around the many health inequities rooted in racism and amplified by the COVID-19 pandemic. So a quick overview of our agenda today. We'll start by acknowledging the pervasive racism in our society's systems and structures and how that has shaped the COVID-19 public health crisis. We'll then provide some background on legal parameters around the pandemic response, primarily looking at state actions and the authority to take such action. Finally, we'll conclude with the discussion of both challenges and opportunities in commercial tobacco control policies moving forward in light of the COVID-19 pandemic. We'll leave time for questions at the end of the webinar, and we have provided a list of many resources at the end for those who are interested. And with that, I will hand things over to my colleague, Jessica Grosz.
Thank you, Rachel. So as Rachel mentioned, we're going to start by discussing a public health crisis that is within a public health crisis, so that being COVID-19 within the public health crisis of racism. Next slide, please. So in order to fully understand the COVID-19 pandemic as it unfolds, we have to recognize the ongoing public health crisis of racism and its impact on individual and public health in the United States. So racism causes social, economic, environmental disparities, among others, which lead to health disparities, as we are clearly seeing during the COVID-19 pandemic. These health disparities are often compounded with a lack of access to healthcare, and even when healthcare is available, Black people, Indigenous people, and other people of color can and do encounter racism in the healthcare they receive. The American Medical Association and other national medical groups like the American College of Physicians and the American Academy of Pediatrics have called on us to recognize racism as a public health crisis, stating racism in its systemic, cultural, institutional, and interpersonal forms is an urgent threat to public health, the advancement of health equity, and a barrier to excellence in the delivery of medical care. Next slide, please. So racism is also a social determinant of health. as many of you may be aware, social determinants of health are the conditions in which people are born, grow, learn, work, live, and age, and the wider set of forces and systems that shape the conditions of our daily lives. The social determinants include these 6 broad areas of life, as shown on the slide: economic stability, physical surroundings, education, food, community and social context, and access or lack of access to healthcare systems. And social determinants can be positive or they can be negative. If you're a Black person, an Indigenous person, or another person of color, all too often they are negative. And this is because racism, which is a form of discrimination, is both a social determinant in and of itself, as you see in the community and social context column of this slide, and it magnifies the negative impacts of other social determinants. If we relate this back to the COVID-19 pandemic, Black people, Indigenous people, and other people of color experience disparately higher unemployment rates compared to white people. And when employed, they often are limited to low-wage work that cannot be performed from home, and that provides little or no sick leave and lack of health insurance benefits. These conditions impact health outcomes generally, and certainly in the context of COVID-19, as you'll see in the next slide. Next slide, please. So in this graph, we can see the public health crisis of racism in COVID-19's disproportionate impact on Black communities, Indigenous communities, and other communities of color across the US, who are more likely to become ill, seriously ill, and die from COVID-19. These racial disparities exist even when socioeconomic status is controlled for. So if you look at the top yellow bar, that represents Indigenous Americans who are dying from COVID at a rate of 36 deaths per 100,000 people. This is known to be an undercount because many states report data about Indigenous people in the other race category. The next bar represents Asian Americans whose COVID-19 death rate is 26.3 deaths per 100,000 people. If you jump down to the blue-gray bar, which represents Latinx Americans, the death rate is 28.2 deaths per 100,000 people. And then the dark blue bar represents white Americans at 26.2 deaths per 100,000 people, which is the lowest rate. But if I draw your attention back to the green bar in the middle, that bar represents Black Americans whose death rate by COVID-19 is 61.6 deaths per 100,000 people. So that is more than twice the rate of most other groups. And collectively, Black Americans represent 12.4% of the population in the US, but they have suffered 24.3% of known COVID-19 deaths. So basically they're dying at twice their population share. The tobacco industry has contributed to these disparities through its creation of highly addictive products marked specifically to Black communities and other underserved communities, who in turn are greater impacted by chronic disease and consequently poor COVID-19 outcomes. So with this background in mind, we're going to turn to what states have done in response to COVID-19 and what can and should be done in the commercial tobacco control context. Next slide, please. So as I said, now we will address COVID-19 responses, starting with state executive orders, addressing the authority to respond, and then ending with some issues related to enforcement in the commercial tobacco control context. Next slide, please. So each state response to the pandemic has been unique because it's shaped by the authority that is available to the executive branch within each state, as well as the political climate in each jurisdiction. So this slide lists the varied options and actions that have been taken by states thus far. Most state responses started from the basic goal of minimizing the spread of COVID-19. However, this was done at a time when there was incomplete information that was rapidly evolving about the virus. While states and the federal government had emergency plans in place for the possibility of a pandemic, the implementation of those plans with limited information was very challenging and will be the subject of debate and analysis for years to come. So despite their different approaches, there were a few common themes across state responses. So first, most states issued some form of an emergency order or a declaration of a state of emergency, which triggered the ability of their executive branch to act to protect the health and safety of state residents. These declarations were followed by a series of executive orders closing schools and closing businesses and directing a wide range of activities to control the spread of the virus. Many states issued stay-at-home orders, which mandated that non-essential businesses and activities be limited to avoid spreading the virus, including essential travel restrictions. Instead of mandated stay-at-home orders, a handful of states issued what was called voluntary directives that urged people to follow CDC guidelines to minimize the spread of the virus. And at the same time, many local jurisdictions were also taking their own steps to protect the health and safety of their residents. And sovereign tribal nations were taking action to protect the public health within their jurisdictions. So this map is from the National Governors Association, and it depicts the current status of statewide stay-at-home orders as of June 23rd, 2020. Since the original stay-at-home orders were first issued in March, many states have significantly scaled back their restrictions. So as we know, sometimes these decisions to reopen were based on public health information, but very often they were based on public pressure from businesses, residents, and local policymakers. You can see that many states have completely lifted the orders that they had in place, while some have lifted the orders but are still providing guidance that vulnerable populations should still be cautious and take steps to minimize contact. In just a few states, California and New Mexico have remained steadfast in their attempts to maintain stronger stay-at-home orders as the pandemic continues. And as you can see, those are the darker green states here. So like states, tribal nations have also issued stay-at-home orders in response to the COVID-19 pandemic. Navajo Nation is the region with the highest coronavirus infection rate per capita in the United States. The death toll equates to a death rate of 177 people per 100,000 people, which is higher than any single US state. A stay-at-home order was issued in March to attempt to control COVID-19's impact on tribal members who already suffer health disparities in part due to inadequate access to food, water, and electricity. And unlike many states in the US that have reopened with few or no restrictions, Navajo Nation maintains a weekend lockdown in addition to daily curfews and business closures. So now we're going to turn to authority and limitations of these executive actions. Authority for the executive orders differs in each state, but most states confer the power to declare a state of emergency to the governor and state agencies to then act to protect health and safety of the state residents. These powers are typically found in a state's constitution and statutes, which enumerate the parameters for exercising the executive emergency powers, and importantly, the limitations of these powers. So most states have built-in checks and balances on the executive actions by providing that the legislative branch has the ability to override an executive order. To give you an example, in Minnesota, an executive order extension of an existing order will trigger a legislative special session if the legislature is not already meeting in its regular session. So this allows the legislature to ensure the executive power is not being abused. A second check on the executive power is the limited duration of the emergency executive order. These orders will typically expire after a set period of time or once the crisis has passed, and the orders cannot go on indefinitely. So if the executive branch wants to extend or partially extend an order, it has to issue a new executive order, which again triggers the opportunity for the legislative branch to weigh in. In these state level orders, there are usually limitations on local action in their response to the pandemic. So usually either the statewide order will put a ceiling on the local power that would preempt the local jurisdiction from going above and beyond its attempts to protect the public health and safety. However, most of the statewide orders have set a floor for the public health and safety protections that allow local jurisdictions to enact more protective public health protections. I also wanted to touch briefly on litigation related to authority. So litigation is another check and balance to executive authority. As you may be aware, in Wisconsin, for example, its Supreme Court struck down the state's stay-at-home order. And in that case, the court ruled that the state's public health secretary did not follow the proper procedure when enacting the stay-at-home restrictions and should have followed an emergency administrative rulemaking process that permits members of the legislature to provide input. And according to the court, without following the administrative rulemaking procedure, there were no limits on the secretary's power. I wanted to note that in an exercise of local authority after the state's Supreme Court order, public health officers in Milwaukee, Appleton, and in other counties put in place their own stay-at-home orders, but a lawsuit has been filed in response to those actions and is ongoing at this time.
Great, thanks, Jessica. So I'm going to turn to drill down into a little more detail about what was actually included in some of those stay-at-home orders and emergency orders. So generally, in defining what is considered essential or critical sector businesses, services, and workers, most states have followed the guidance from the U.S. Department of Homeland Security. Their Cybersecurity and Infrastructure Security Agency, or CISA, has issued guidance to help define some of those terms. And this guidance by CISA is advisory. It's not to be considered a directive by the federal government to the states, but states have gone on to amend and interpret the CISA guidelines, sometimes with more narrow interpretations or definitions, while some other orders appear to have looser restrictions on what is considered to be essential or critical sector, therefore allowed under their individual state orders. However, as you would expect, once there was an attempt to draw any lines around some of these components of an order, more questions of interpretation and need for clarification emerged. The primary question we heard from jurisdictions was whether vape and tobacco shops were considered essential businesses and allowed to remain open. And often the answer was not very clear-cut. Most states did not address vape and tobacco shops directly in their definitions, so there was some level of interpretation needed. Additionally, the activities allowed for different types of businesses varied. So many states completely closed non-essential businesses, but would still allow remote work or allowed minimum basic operations to continue. So basically keeping the lights on. So a further complication was whether the orders allowed for delivery, curbside pickup, or shipping. Often whether delivery was allowed depended on whether delivery was considered essential travel, which was also dependent on the other definitions of essential services. So as you can expect, there was a fair amount of confusion as states and local governments tried to sort all of this out. And I want to share a few examples of states that handled this question about vape and tobacco shops being open in very different ways. So first, in Iowa, Governor Reynolds issued a proclamation of disaster emergency that required businesses, services, and facilities to close. Included in the mandated closures were tobacco and vaping stores. So here is language as it appeared in the proclamation. And this is an example of very clear direction about whether tobacco or vape shops were allowed to remain open. And the answer in Iowa was no. North Carolina's executive order generally closed non-essential businesses, but did allow businesses to apply to be declared essential. So this bar graph is from an article published by the Charlotte Observer, and it shows that the vast majority of businesses that applied for essential status were deemed to be essential. And this was a significant loophole. And as was reported by the Charlotte Observer, during the period that they were analyzing these applications, they specifically noted that 6 tobacco and vape shops were granted essential status. So the third example I wanted to talk about is the state of Kansas, which provided guidance on how the statewide stay-at-home order defined essential functions. This was one state that explicitly named vape and smoke shops as essential, and specifically for the sale of nicotine and CBD products. So this is the excerpt from guidance on their online guidance document. So another area I wanted to drill down a little bit was with enforcement of the executive order. So there was also a lot of confusion about enforcement, despite some of the guidance that had been issued on an ongoing basis from the different states. The enforcement parameters were often not clear, or they were not clearly communicated to enforcement authorities. So another concern were the penalties for violating the stay-at-home orders. Most states and jurisdictions, these penalties were quite steep. In Minnesota, up to $1,000 fine or 90 days in jail was the potential penalty. And then on top of that, penalties were often stacked, meaning that if a person was pulled out for a taillight being out, for example, they may also be hit with a penalty for violating the stay-at-home order. And then, of course, there is also concern about the likelihood of disparate enforcement of the orders against Black, Indigenous, and people of color. But the bottom line is clear direction is needed to guide appropriate enforcement. A good example of what communities could do proactively is this letter, an excerpt of which I have provided from the city of St. Paul, Minnesota. They sent this letter to all vape and tobacco shops in their jurisdiction. It clearly directs those shops to remain closed under the statewide executive order. So this is a good lesson from one jurisdiction about what proactive steps communities may be able to take in the future as these stay-at-home orders may resurface. So now as states are reopening, we are seeing a real evolving landscape. Statewide orders were initiated from a basic premises of attempting to minimize the spread of COVID-19 and to protect the health of residents. I would argue health should remain the guiding principle for when and how to reopen. However, as experience is showing, it may not be that clear cut. The CDC has offered guidance on stages for reopening, but it's important to note that to our knowledge, states are not following these guidelines in their stages of reopening. And this leads to the fact that local jurisdictions have been and continue to be at the front lines of solving many of these challenges in real time. It's important to allow local communities the flexibility to provide greater public health protections and respond to the public health needs of their particular jurisdiction. And this is a lesson that we know well in the context of commercial tobacco control. So that brings us to the more specific discussion about commercial tobacco control challenges that have been brought into greater focus by the pandemic and the policy opportunities for moving forward. And I'm going to start by talking about the point of sale context, where jurisdictions have strong licensing requirements and clear restrictions on sales of commercial tobacco products. An important lesson learned is they should first and foremost ensure that all of those existing laws are being followed and enforced. So this is not the time to weaken enforcement, and we did see some glimpses of that especially in the delivery context where some solid age verification practices were weakened or were not followed. So, but where laws are less stringent or where there are gaps or exceptions allowed, we definitely saw more challenges in communities. Some examples of some good policy opportunities, and these should be very familiar to you commercial tobacco control advocates. We know that strong commercial tobacco control policies are needed always, but particularly during the pandemic. So as I mentioned, strengthening age verification practices and requirements is an important strategy always, but particularly now with the use of masks and, as I noted, an increase in businesses using delivery as the way of selling their products. So another area is compliance checks. It's important to protect the safety of decoys and, moreover, again, to ensure that compliance check process continues. This is not the time to back down on making sure that the rules are being followed. Jurisdictions could honestly solve a lot of problems with age verification by just simply prohibiting delivery and curbside pickup, or even prohibiting online sales altogether. In terms of reducing the density of tobacco retailers, another important policy area, stronger local laws to limit the location, number, and density of tobacco retailers is more important than ever to reduce access. COVID-19 executive orders have demonstrated that tobacco and vape shop closures will benefit communities that have been hardest hit by the pandemic. Finally, a word about the complete removal of products from the market. These kinds of bold endgame strategies are being explored in a growing number of communities, and the pandemic could be a catalyst for that discussion to move forward. So another challenge that was brought into even greater focus with the pandemic is the industry's targeting of Black, Indigenous, people of color, and LGBTQ communities, many of whom are experiencing the greatest health challenges due to the pandemic. Along with many of the point of sale strategies I already mentioned, an important policy strategy to address this industry targeting is to end the sale of flavored tobacco products. The FDA should take the step of prohibiting menthol cigarettes and all flavored tobacco products. State and local jurisdictions can also step in where the FDA has failed to act to remove these harmful flavored products. And finally, investment in culturally specific programs to help people quit is a very important step to counter this targeting by the industry. So the recent recession has created significant budget challenges for states and local jurisdictions. And this is at the same time there's increased demand for the very programs that help reduce the burden of the pandemic on residents. Along with budget impacts, public health has also been overwhelmed as staffing in state and local public health offices have often been redistributed to address the pandemic. And one opportunity that is being explored in a number of states already is to increase taxes on commercial tobacco products. From a public health perspective, the benefits of increasing the tax are twofold. So it would help raise much needed revenue for public health programs while also raising the price of commercial tobacco products. We anticipate that with the pandemic, there is an increase in the incidence of smoking and greater need for cessation and nicotine addiction recovery support. So any new revenue that is raised through additional taxes should be channeled directly into supporting cessation services. The industry will certainly ramp up their strategies to provide discounts and coupons to counter any higher taxes. So state and local governments should consider policies setting a minimum price and pack size for products and prohibit the redemption of coupons and price promotions. Again, the pandemic is an opportunity to pursue bold commercial policy strategies. And these are some some examples of those.
Thanks, Rachel. So I'm going to conclude our presentation by addressing a few more opportunities and challenges. So while people have been working from home during COVID-19, and as people continue to work from home, it's likely that there's been an increase in exposure to secondhand smoke, both to those that are living in multi-unit housing and also those who live with individuals who smoke. So this reality creates the opportunity to pursue or renew efforts to enact smoke-free multi-unit housing policies in our communities. Businesses are also using COVID-19 closures as an opportunity to reopen as smoke-free businesses. And this protects customers and workers during a time in which minimizing risks to one's health is as important as it has ever been. Sovereign tribal communities have demonstrated particularly strong leadership in their push to reopen many casinos as smoke-free during this time. And additionally, I wanted to note that any efforts to push for more smoke-free locations should be coupled with robust and culturally appropriate cessation information and resources. The tobacco industry is also using COVID-19 as an excuse to push for delays in implementation of key commercial tobacco control policies like graphic warning labels for cigarettes and policies to prohibit the sale of flavored products. To provide you with an example, the New England Convenience Stores and Energy Marketers Association pressed Massachusetts Governor Charlie Baker to use his executive authority to delay a law restricting the sale of flavored tobacco products, including menthol cigarettes, that was scheduled to go into effect in the state on June 1st. He refused, and that law is now in effect. And that is exactly the right approach. Right now is not the time to delay on commercial tobacco control policies. Now is the time to push for comprehensive commercial tobacco control. The industry is also using COVID-19 and police brutality against Black people as a public relations opportunity to paint itself as the good guy. It's donated medical supplies, money, and it's even created branded face masks in response to COVID-19. As you'll see on this slide, it has released racial equity statements like this email from Philip Morris on Juneteenth. We all know it is using this particular moment in our country and world as an opportunity for profit. The industry continues its health harming practices by, for example, continuing to initiate lawsuits throughout the United States to attempt to prevent flavored tobacco product sales restrictions from going into effect. Our opportunity is to continue our work of exposing the industry for what it really is. The tobacco industry is never on the side of public health. I wanted to note as well that right now obviously is a time that brings a tremendous amount of trauma, social isolation, job loss, and more. And so it's reasonable to expect that there may be an increase in commercial tobacco use right now. So again, wanted to point out that this is an opportunity for us to push for comprehensive, accessible, and culturally competent cessation support. And finally, an additional challenge that we are seeing is that during COVID-19, schools and workplaces are having to work to change their policies and practices to accommodate the pandemic. While they're reviewing their policies and practices, this is a great opportunity also for them to be reviewing their policies and practices as it relates to tobacco-free measures. It also is a wonderful time to focus on providing cessation and mental health support to both workers and students. And this image points out one of the many resources on our website, which is a commercial tobacco-free K-12 school model policy. We wanted to conclude by stating that if a long time ago governments had enacted comprehensive commercial tobacco control measures that protected all communities from the predatory tobacco industry, we likely would not be seeing the tobacco-related health disparities that we do today, and may not have seen such stark racial disparities in COVID-19 outcomes. We know that there are comprehensive commercial tobacco control laws and policies that can advance health equity for all communities, and comprehensive commercial tobacco policies reaffirm communities' rights to be healthy, resilient, and less susceptible to the harms associated with the COVID-19 pandemic and with future potential pandemics. We've listed some resources as well, resources that touch on racial justice and health equity, that touch on state pandemic responses, as well as listing some of the resources that you can find both on our website and on ASH's website related to COVID-19 and also related to commercial tobacco control measures. And we want to remind you that although we are working remotely, we are still fully operational. And so if you have any questions related to this webinar or any other legal technical assistance questions, we are available to answer them for you.
Okay, thank you very much, Jessica and Rachel. A very comprehensive presentation. We have a few questions already, and if you haven't asked yours yet, the Q&A button at the bottom is where you enter them. I wanted to really quickly emphasize something that, our speakers mentioned. This is not a retrospective. COVID is going to be with us for some time. We're also only in the beginning of lockdowns. I think we're going to see more waves. We are certainly seeing second waves in states that reopened too early. And of course, we're not going to end 400 years of racial injustice by passing a few new laws. So we hope that some of this information that you've heard today can be used to move the needle in the right direction going forward. So thank you for indulging me there. Let's open up the questions, and we have a few already. I'm going to take my prerogative and ask a question first. In terms of governor's executive authority, would it extend to increasing access to cessation? Because as you mentioned, if states are going to get rid of access to cigarettes and other tobacco products, cessation is going to become vital. But is that a budget issue that only the legislature can do, or can the governor say free NRT for anyone who wants it for the next 2 months or something like that?
That's a good question. I mean, I think it obviously would depend on the state and what kind of discretion each state has for reallocating resources like that. But I think that's a great idea. If I happen to know that, for example, in the state of Minnesota, the Minnesota Department of Health was able to make the case that instead of reallocating staff away from their commercial tobacco control cessation services to help fill in for the pandemic response, they were able to make the case that it was important that the state continue to invest the same level of resources in those programs. But I think that is a very good thing to pose to states moving forward, as we know those who are experiencing some of the toughest health outcomes from the pandemic are people who are addicted to nicotine and smokers. So that would make perfect sense.
Jessica, anything to add?
Yeah, the only thing that I would add is, as we mentioned, the executive orders are temporary. So even though that could help on a temporary basis, in terms of a long-term approach, the best approach would be legislative action. In the context of the vaping epidemic that happened and the emergency or temporary action that was taken by states, one positive outcome from that is that it did at times help to shed light on an issue that needed to be addressed, and in turn there was legislative activity in some states as a result. So certainly a coupling of both temporary action to shed light on the importance, and then permanent action to make sure that there's concrete and measures in place on a long-term basis in terms of cessation would be one possibility based on having seen the vaping epidemic, temporary and permanent measures play out a bit more than the ongoing crisis.
Great, thank you. I have two questions that are similar, so I'll ask them together. The first is do you have any recommendations on how to conduct enforcement and compliance checks safely for the, especially the underage kids that are going in to pretend to buy cigarettes? And also, do you think it would be a legally defensible argument for a clerk to say they were wearing a mask, so I thought they were older than they actually were?
Yeah, those are very good questions. I don't have a simple answer on the compliance checks and best practices. I know that a lot of departments of health and the CDC are looking at how to ensure that compliance checks can be conducted safely. So I don't have a quick, easy answer on that. But very interested to hear what people are doing around the country on that front. And then I think to answer your question about using the wearing of a mask as an excuse for why a clerk perhaps thought someone was not of age, I think if anything, the wearing of masks should probably increase the amount of age verification that's happening, because it is going to be harder to determine if someone is who they are with half of their face covered up. So I think it would, in terms of legally defensible, it would really depend on the exact circumstances of the situation. So I think it, as so often, it depends.
Jessica, anything to add?
Yeah, I would just add that in terms of making sure that compliance checks are being conducted in a safe manner, it's worthwhile to look at other industries to see how they are protecting workers during this time, because it is essentially a matter of workplace protection. So looking at practices in terms of, mandatory temperature checks or providing protective equipment or other supplies that could provide additional protection. Certainly just using this as an opportunity to look at the ways that other industries are protecting workers could be a little.
Great, thank you. The next question is really interesting for me. It's whether there's been any data on the correlation between the various responses to COVID and smoking rates, especially smoking rates on the basis of age, gender, ethnic background, etc. And I'll start by saying I don't know of any data like that other than in South Africa, where there was a study done on their lockdown and closing of tobacco stores, but maybe our guests know more about it.
I mean, I can say anecdotally, what we are hearing is we're hearing of more complaints of increased smoking in multifamily housing context. I know of one organization that did a student survey to just check in with students to see, are they vaping at the same rate, increased rate, and they surprisingly found that they found more youth answering that they had increased their incidence of vaping. So I think at this time, I'm only aware of that anecdotal information, but it is, I think, going to be really important to try to understand some of those dynamics. I think what we have learned from traumas of the past, like 9/11, is that when people are stressed and experiencing trauma, they tend to increase their use, or sometimes people who have quit smoking or using nicotine products will return to using products. So, these are all questions that are going to be hashed out in the months and years to come. But I think what we would really point to is we should never be backing down on supporting cessation. And I think, Chris, as you pointed out, it's even more important for states and local governments to be increasing their supports and investment in cessation, because we do anticipate that there is going to be a potential increase in use.
Jessica, anything to add?
No.
Okay. The next one is a straightforward and probably not an easy one to answer. How do you prohibit and enforce online sales?
That is a very good question, and not an easy one to answer. I think, you know, I'm aware of a handful of states that have attempted to regulate in this area, and some local jurisdictions that have attempted. And I think my understanding is that the more statewide approach tends to be easier to enforce because you're not parsing out different jurisdictions. So I think that would be, you know, one way of looking at the issue. And, you know, I will note that we have some really great resources on our website that I can direct people to learn more about effective policies for prohibiting online sales. But I think those are also going to be important, and restricting delivery of products too is going to be a really important discussion for the future.
Jessica?
Yeah, we recently had a webinar regarding this issue and also have a printed resource. So like Rachel said, I certainly would encourage you to check out our website and check out those resources that are particularly on this topic.
Thank you. The next question is any research being done that connects secondhand smoke exposure to exposure of the COVID virus? And I suppose they're talking about comorbidity. And let me start by saying that I'm not aware of any, but I'm almost certain there is research going on. Just it is a topic in the research community of discussion. So I'm sure somewhere somebody is doing this, but maybe Rachel or Jessica knows more specifically.
Yeah, I'm not aware of any specific studies, but it's definitely an important area that ought to be studied for any researchers out there.
Yeah, I also haven't come across any particular studies on that issue.
Okay. If we find some, we'll post on our website on our COVID page. The next one is on smoke-free air, and you brought it up a bit about businesses reopening and taking advantage of the fact that they have a hiatus to go smoke-free. But this question is on outdoor seating, especially expanded outdoor seating for restaurants. And the questioner is from New York City, and he's wondering if it's to change the 25% outdoor seating that allows smoking thing, or if they're doing anything at all to enforce or even give guidance on that. And maybe you've heard from other states how they're handling that.
Yeah, I mean, I can't speak specifically to the New York law, but I will say that from our perspective, if you have comprehensive smoke-free clean air laws, those should be fully enforced, and it would not be an excuse to, you know, if you have, say, a 25-foot setback or buffer zone from doorways, windows, etc., this would not be the time to start not enforcing those requirements. So I think, you know, of course, our default is that the stronger policies should be enforced always and not just during the pandemic. And so I don't think we would have a different opinion of that given increased outdoor seating at restaurants.
Jessica?
Yeah, I agree. I just echo what Rachel was saying.
Okay. The next one is probably fairly simple to answer. Do you have a commercial tobacco-free model policy for institutions of higher education? My guess is yes.
So non K through 12.
No, so higher education. I assume they mean college. And
yeah. At this time that we don't have one specifically for higher education, but we certainly It's something that we are working on, and we have provided legal technical assistance on this issue, because some of the considerations and challenges obviously are outside of the realm of a model K through 12 policy.
Next question is, this pulls in the racial justice issue, and they're asking, are there any discussions in places that, as of now, use police and sheriffs to do compliance checks to move away and give that enforcement authority to other organizations in order to avoid the disparate enforcement?
Yeah, I am not aware of any specific discussions, although I am generally aware that many school districts, for example, have severed or scaled back their relationship with law enforcement in terms of enforcing school policies. And so I think that's also a really good conversation to be having right now is, and it's something that we have explored extensively is, sort of removing the criminalization of violations and removing the interaction or reducing the interaction with law enforcement, which continue and, if anything, are brought into even greater focus by recent incidents in Minnesota and other jurisdictions.
Yeah, I would just say anecdotally, it's a conversation that's being had within the commercial tobacco control community, and certainly in the legal technical assistance that we provide when we're working on policies and we're addressing enforcement. Having that conversation about who really is the most appropriate enforcement mechanism when it comes to public health. Would that be law enforcement, or would that, for example, be a local or state health department? As Rachel said, certainly in light of the current crisis in our country and in the world, that's kind of bringing those conversations to the forefront about what is appropriate in terms of enforcement.
Thank you. The next question is similarly on racial justice issues. They're wondering about the groups that are now exploiting the Black Lives Matter momentum to block attempts to ban menthol cigarettes and other tobacco products, arguing that that's going to put people of color at increased risk for law enforcement mistreatment. They said we know all the counter arguments, but they wondered if you had any thoughts on how to proceed against menthol in the current climate.
Yeah, I mean, I can chime in on that question. I think just to have the full understanding of the impacts of the sale of menthol cigarettes on the health of certain communities and the Black community in particular, that it has been a problem. It continues to be a problem, that the industry targets communities, especially the Black community, with marketing and sales of those products. And so knowing what we know about the disproportionate impact of the COVID pandemic on those same populations, in our view, heightens the need to be focusing on those policy areas to really protect the health of people. And that should, in our view, be something that we continue to move forward with. I think, as the previous question, being very mindful and thoughtful about how some of these laws are enforced, that is going to be a continued discussion, and reducing that interaction with law enforcement is a really key, I think, part of our goal with model policies that we work on. So, Jessica?
Yeah, certainly I echo what Rachel is saying, in that something that we really work on in our work is making sure that the appropriate party is penalized. So not, for example, the person who may be purchasing a tobacco product, but the retailer. The responsibility should be on the retailer. But also just as you know, as has been brought up in recent webinars through ASH as well, that the impact on Black lives of menthol is astounding. The number of people who die on an annual basis because Black people who die on an annual basis because of tobacco use and menthol particularly is astounding, and we can't lose sight of that, because by pushing forward on menthol, we're helping a substantial amount of people in hopefully not continuing to have these really gross, disparate health impacts.
I think we have time for just one more quick question. How effective are efforts to engage with Indigenous peoples to overcome the compounding effect of COVID-19 prevalence and failure of tobacco control in those communities? That might be a difficult one to answer, but maybe you can wax philosoph on it.
Yeah, I mean, I don't have a great answer on that one either. I mean, I think that as Jessica pointed out, the Navajo community has been particularly hard hit by the COVID-19 pandemic. But I think, as always, we need to be turning our attention to those who are disproportionately by the health harms of, tobacco use. So if anything, it really argues for stepping up and really taking seriously the investment and creation of programs that we need to really address these public health issues.
Jessica, anything to add?
I would just say that it's really important to forge community partnerships. And if we're going to take an equitable approach to commercial tobacco control, that means that no group of people is left behind, and that we need to tailor our work so that health outcomes for all are improving.
Great, thank you. So we're a bit over time. I want to thank everyone for joining us today. We have been recording this webinar, so it will be posted on the ASH website, and I look forward to getting back with you all in the future. Take care.